right, good afternoon, everyone. It is 12 o'clock, so we'll go ahead and get started. It is my privilege to introduce my colleague and friend from the University of Michigan, Dr. Hallie Prescott, who is our speaker today. Dr. Prescott is an associate professor of medicine with tenure and a core investigator at the VA CCMR. She completed her medical education, residency, and chief year from The Ohio State University. She then saw the light and joined the University of Michigan as a pulmonary critical care fellow and completed her training there in 2014. During her training, she completed a research fellowship under the tutelage of Dr. Jacka Washina and many others to the NCSP, which is where our paths first crossed. Although Hallie reminded me today that I had consulted her on a patient in 2011, which I do not remember. So we have a long history together. In a very short time frame, Dr. Prescott has risen to the ranks of associate professor with tenure at Michigan, and I anticipate she will be a full professor very soon in the near future. As many of you hopefully know, she's a leader in the field of sepsis and has really done incredible work understanding distinct phenotypes of sepsis and trajectories of patients with sepsis within and beyond the ICU. This work has led to years of sustained funding from the NIH, the VA, the CDC, and AHRQ, among others. She is currently supported on numerous R-level grants. Her work has informed national and international guidelines related to sepsis, including those from the Society of Critical Care Medicine and the ATS. I could spend the next hour telling you about the many awards and accolades that Hallie has won. However, many of these have been within Michigan and beyond, including from within the ATS, the Sepsis Alliance, and ASCI. Dr. Prescott has published over 130 peer-reviewed articles in leading critical care and medicine journals. She has delivered over 100 national and international invited talks on the topic of sepsis, hospital approaches to improving sepsis care, and data-driven quality improvement. I know that we are in for a real treat today. Please join me in welcoming Dr. Hallie Prescott to Medicine Grand Rounds.
Excellent. Well, thank you for the invitation to be here. It's been really fun being in Colorado and catching up with some friends, meeting some new people. I had some great talks today and looking forward to giving this talk. So I'm going to be talking about data-driven performance improvement in sepsis. I have no financial conflicts of interest. I've listed research funding and salary support. And then I have some pertinent roles I'll disclose up front. I serve as co-chair of Surviving Sepsis Campaign Guidelines currently, and then I lead a statewide sepsis quality improvement initiative in the state of Michigan that you'll learn more about today. And then otherwise, just obliged to tell you these are my views, not necessarily views of the US government, Department of Veteran Affairs, or other organizations. So in terms of outlines, I'm just going to give a little bit of background on sepsis and me and my research program. I'll then move into a patient case. I'm going to spend really a lot of time talking about antimicrobial timing for sepsis, diagnostic uncertainty for sepsis, and how we sort of balance those two issues to sort of drive care forward with guidelines and bedside care. So high-level background, why is sepsis important? This is a really common cause of hospitalization, estimated about 50 million hospitalizations worldwide annually. This is a major driver of inpatient mortality, estimated that it contributes to more than a third and up to maybe 1/2 of all inpatient hospital deaths in the US. And it's also a major driver of longer-term morbidity among patients who survive hospitalization. So new or worsened cognitive impairment, functional limitations, health deterioration and hospital readmission, increases in risk of mortality for weeks and even years after surviving sepsis, and then many patients who really are challenged to go back to their work or prior activities. So at a high level, it's a very important public health problem. And so the bulk of my research program and career has really been focused on trying to improve these longer-term outcomes from sepsis, doing that by trying to improve the delivery of kind of recommended care practices across the continuum from very first recognition and even sort of pre-hospital recognition all the way out to recovery and supporting patients after sepsis hospitalization. And there's kind of a variety of different tools, I would say, in the toolbox that I've used in this. The sort of backbone has been kind of health services research, rigorous observational research. but then increasingly involvement in clinical practice guidelines, performance evaluation, and then more recently, large-scale quality improvement and implementation. So I have a joint appointment between the Ann Arbor VA healthcare system and the University of Michigan. And on the VA side, I run a research program within our VA Center for Clinical Management Research. This is essentially a large health services research center of innovation, and I have a small team kind of nested within there. And we use nationwide VA electronic health record data to understand care practices in the VA and to try to learn from the variation and understand what are those practices that are associated with better outcomes, how can we, facilitate the implementation of those to improve care across our system. And so currently I have grants ongoing related to antimicrobial prescribing patterns for potential infection, and I'll share a number of papers that came out of that grant, and then another grant related to supporting veterans in their recovery after sepsis, which I won't have time to talk about today. On the University of Michigan side of my appointment, I have been involved since 2020 in the Hospital Medicine Safety Collaborative Quality Initiative. This is a large-scale collaborative quality program that's funded by Blue Cross Blue Shield of Michigan. And Blue Cross Blue Shield is kind of the dominant private insurer. It has about 85% market share in the state of Michigan and has this kind of like long-standing history of investing money into statewide quality improvement programs. So this started in the 1990s with the development of a number of surgical quality improvement collaboratives. And then in 2010, they started funding this Hospital Medicine Safety Initiative, which is really geared towards trying to improve care and outcomes of the hospitalized medical patient. Currently, we have 69 hospitals in the state of Michigan that participate. Essentially, this is all of the large and medium-sized hospitals and even a number of the smaller hospitals throughout the state. And within this kind of larger umbrella of the Hospital Medicine Safety Initiative, or HMS, there have been a number of kind of targeted initiatives that have been run. The first one was blood clot prevention, so like DVT and PE prophylaxis. Intravenous catheter use. This was an initiative run by your own Dr. Vineet Chopra, and if you look closely, you'll see him in that picture of our coordinating center. Antimicrobial use and stewardship. We ran a program related to COVID, which is now retired. And then the newest program, which I have been leading, is our initiative related to sepsis. And so for this statewide initiative, HMS does a number of different activities to really try to foster and instill quality improvement across the state. So we do audit and feedback. We run a statewide registry of sepsis admissions, and we provide quarterly reports to our hospitals about their performance, and that's benchmarked to their performance over time and against other hospitals. And then we maintain a live interactive website so they can kind of see performance in real time and understand whether local interventions are moving the needle at their hospital. We do a lot with networking. So we bring our hospitals, all 69 of these hospitals, together 3 times a year to provide updates, to provide education, and to really invite our high-performing hospitals or hospitals that have improved things in recent past to share their successes and learnings with the rest of the hospitals to, again, try to catalyze improvements across our whole state. We do a lot of things to sort of develop and curate tools and resources to help our hospitals. So these are things like educational tools, documentation templates, example order sets that they could use and locally adapt, protocols, and we maintain all of these in a toolkit that's online for them to access. And we've collaborated very closely over the past couple years with the CDC to try to develop some of these things more nationally. We partnered on developing the Hospital Sepsis Program Core Elements. These were published last year in September for Sepsis Awareness Month, and essentially is a high-level guidance about the structures that hospitals should have in place to monitor and improve the management of sepsis in the hospital. We do a performance index. This is perhaps the most controversial aspect. So there is a pay-per-performance element to our collaborative, and all of our hospitals get scored on an index annually. About 30% is related to participation, so that's timely and accurate submission of data, and about 70% related to performance. And this then is tied to financial incentives or reimbursement for higher performing hospitals. And each year, we carefully kind of adjust that index to continue to nudge care forward. And then the last key element is hospital site visits, doing grand rounds type presentations, also reviewing hospital processes and structures, and providing formative feedback. This model has had a long track record of success, starting with those surgical collaboratives, but even the initiatives within HMS. So I'll just provide some numbers from some of the longer standing initiatives. So Dr. Chopra's initiative on IV catheter use has had huge success in terms of prevention of clots, catheter occlusions, infections avoided, and so providing a very strong return on investment to our funders. Likewise, antimicrobial use and stewardship has had substantial savings in terms of unnecessary antibiotic prescribing, many of this kind of unnecessary prescribing at the time of hospital discharge, which seems to be a kind of a hole in some of the hospital-based stewardship efforts. So with this background, I'm now going to move on and share a patient case and move on to talking about some more sepsis research. So this particular patient was a 67-year-old male, had cardiac disease, severe ischemic cardiomyopathy, reduced ejection fraction, and presented with several days of shortness of breath, difficulty laying flat, leg swelling, but also productive cough and fevers. Patient had a temperature of 37.9, tachycardic with AFib, marginal blood pressure, tachypnic, and then satting 88% on room air. This patient had JVD, peripheral edema, and scattered rails. And on their initial evaluation, they had a white blood cell count of 12.5, so kind of marginal, lactate 2.1, kind of marginal. Creatinine was 1.3, up from a baseline of 1, and then the chest X-ray showed evidence of both pulmonary edema and a focal consolidation in the left lower lobe. And so this patient is treated with fluids, antibiotics, IV diltiazem, and continues to decline. So blood pressure drops, noted to have cooler extremities, rising lactate, and then ultimately gets intubated and transferred to the intensive care unit. And so we will return to this particular patient case a little bit later in our talk. So I'm now going to move on and talk about antimicrobial timing for sepsis. This has been really a huge focus of sepsis quality improvement nationally and internationally for the past decade and beyond. And so in the Surviving Sepsis Campaign guidelines, historically, we'd had this recommendation to give antibiotics within 1 hour of recognition of sepsis, regardless of whether this is sepsis or septic shock. And I think that this was leading to a lot of issues at the bedside because we frequently have patients, kind of like the patient that we just discussed, where it's a little unclear, is the driving issue here heart failure? Is the driving issue infection? Do they have both? I'm not really sure. And people would kind of get stuck in the circle, well, gosh, maybe it's sepsis. I only have an hour. I better give antibiotics. And then, on they go. And there was almost less focus also on sort of de-escalating or stopping those antibiotics or sort of reassessing that question. And so we kind of did a rethink on this with the last publication of the Surviving Sepsis Campaign guidelines, and instead came forward with this kind of framework for thinking about antimicrobial timing. And we stratified this based on, well, how likely at this moment do you think that is that the patient has sepsis? And really by that, we mean bacterial infection causing sepsis. And then how sick is this patient, which we relatively simply dichotomized as, are they in shock or have low blood pressure or not? And so if you think this patient definitely or very probably has sepsis, the recommendation is give antibiotics immediately, ideally within 1 hour. This is exactly what the prior recommendation was. If sepsis is possible, right, these are the patients coming into the emergency department, coming into the ICU, you're still trying to get to know them. The recommendation now dichotomizes based on if this patient is in shock, it says this patient is critically ill, you don't have a lot of time to sort of figure this out, you need to make a decision relatively immediately and give antibiotics within an hour unless you're very clear, and it's very clear that this is not due to infection. And then of course, continue to reassess whether it is infection and stop those antibiotics if it turns out to be something else. But we now carve out this time. So for patients where sepsis is possible, they're not in shock, the recommendation, instead of giving these antibiotics potentially within 1 hour, is to do a rapid assessment. So look for infectious, non-infectious causes of illness, get a better understanding of the picture, and then circle back within 3 hours to make this decision. And so this framework is really trying to balance these kind of two competing issues. One is that time to antibiotics matter, which has been seen consistently in a number of these kind of studies I've got cited at the bottom of the slide here. And then consistently in these studies, they seem to particularly matter in patients with hypotension, low blood pressure, shock. And so that's why we dichotomized that in the guidelines. And it's trying to balance this importance of time to antibiotics against this other big issue of diagnostic uncertainty and not knowing immediately when that patient first arrives whether they are in shock. So trying to sort of be mindful of both issues. There have been a number of critiques over the years about this kind of antibiotic timing literature or this kind of focus on time to antibiotics and sepsis. And I don't have time to go over all of them because there are many, but I've picked out 3 things that I'll try to address throughout this talk. First, there's been some concern after this Surviving Sepsis Campaign framework that shock and non-shock is sort of too simplistic of a dichotomization. We use that because that's really what the prior studies had looked at, and these are evidence-based guidelines, not really expert, opinion-based guidelines, but based on the literature, and that's really what had been borne out in the literature consistently. But we'll talk about, whether there's other things that we should be thinking about. The other critique has been that all of this data really is, I would say, high-quality observational studies, and that people have brought up this concern that, well, gosh, this isn't really being borne out in the one clinical trial we have that looked at this, which is the fantasy trial. And I'll give you my thoughts on that. And then the final critique is that there's been maybe just really too much focus on timing and not enough focus on, well, what are the actual antibiotics that are being prescribed? And so I hope to cover all of those issues as we go through this talk. So starting with this issue of, dichotomizing shock and non-shock, and are there not other kind of important patient subgroups that we should be honing in on? I'm going to share the study that was published earlier this year. This was led by Rachel Heckman, who's one of my mentees at University of Michigan. She's one of our recent fellowship graduates and now on our T32 training program. And so Rachel sought to look, are there other characteristics, beyond shock that are associated with a greater benefit of timely antibiotics in patients with sepsis? And the methods that we used to do this analysis were what's called a causal forest. So this is sort of a derivative of a random forest. So a random forest is a tree-based ensemble machine learning model that differentiates kind of high risk of the outcome versus low risk of the outcome patients. Causal forest kind of takes this one step further. And instead of doing high or low risk, it's like high likelihood of benefiting from shorter time to antibiotics versus it doesn't really matter. This patient doesn't have a huge difference whether they got antibiotics sooner. So it's differentiating patients based on a treatment effect as opposed to based on a risk. And this method has been increasingly used as kind of a newer, maybe more robust way to look for heterogeneity of treatment or subgroup differences in clinical trials. And we applied it to this kind of observational framework with risk adjustment. So we looked at 273,000 hospitalizations at nationwide VA and then Kaiser Permanente, Northern California. And we looked at a number of different characteristics: age, sex, presenting SIRS criteria, presenting acute organ dysfunctions, and then chronic conditions to say, what are the factors that really seem to be most important to differentiate whether this is a patient where it's very important that you urgently treat with antibiotics versus one where it's not going to matter as much. And when we applied this, we did see that we were able to sort of clearly separate patients into a wide spectrum of where this was critical and where this is not. And the 3 factors that were kind of by far and away the most important to differentiating patients for whom time to antibiotics is more critical was, interestingly, the number 1 factor was metastatic cancer in their past medical history or in their current history. Shock, so again, sort of very consistent with what we already knew, but that fell out as the second most and very close to metastatic cancer. And then third was acute hematologic dysfunction. And on the right-hand side of the slide, we plotted out from this paper the actual association of time to antibiotics with mortality in the shock and non-shock patients using a spline-based model that really is able to look at the association. And so you can see in the non-shock patients that the mortality risk does increase, but it's, relatively more flatter. And it's really only after, maybe 4.5 or 6 hours that we're seeing like more measurable harm. By contrast, these patients who present in shock, you see a very steep increase in mortality really in those very early hours. So sort of a clear difference in these types of patients. And so I think this paper was important for kind of validating the importance of shock, but also bringing up some other clinical factors that maybe hadn't been on the forefront of people's decision-making, things like metastatic cancer, which I think maybe is a signal that more likely, that this patient truly does have bacterial sepsis or acute hematologic dysfunction, which is, again, probably associated with a very high risk of illness. So I'll now go on and talk about this next concern, and this is the fantasy trial. So the fantasy trial was a clinical trial published in 2018. This was a multi-center clinical trial done in the Netherlands, where they randomized patients in the ambulance en route to the hospital to either getting IV ceftriaxone in the ambulance versus usual care where they go to the hospital and they get antibiotics sometime after arrival. And so patients in the intervention ended up getting their antibiotics on average about 26 minutes prior to hospital arrival, compared to about 70 minutes after hospital arrival. So in total, 96 minutes faster. Despite this 96 minutes faster, mortality was similar. So specifically 7.8% in intervention versus 8.2% in the control. So 0.4% absolute mortality reduction, which in this population of less than 3,000 patients was not statistically significant. And so people have said, aha, this whole thing about time to antibiotics, it's really overblown. The fantasy trial was negative. And my interpretation has always been different, and that this study is completely consistent with what we've seen in the observational data. So important differences are, this was a less sick population. The 28-day mortality was 8%. All those prior studies, generally, it was like 20 to 35% mortality. And then we've talked about how this is particularly important in patients with shock. Only 3% of this clinical trial population was in shock. And so when we look at this figure from Rachel's study, I kind of circled exactly what this study is honing in on. It's looking at a difference of antibiotics of 90 minutes in this very early period among patients who are not presenting in shock, where exactly what you would expect is a 0.4% mortality reduction if you applied the stuff from the observational study to this population. So my interpretation has been that this is completely consistent with what we've seen elsewhere. So timely antibiotics consistently associated with improved survival across larger, higher quality observational studies, association consistently stronger in the sicker patients, particularly in shock. Fantasy trial, I think consistent. And then certainly there are always kind of limitations to observational data, even with all the kind of robust methods we can do. But I think it is reassuring that a number of different analyses have really all come out with consistent findings, suggesting sort of similar findings related to benefit. We will have some more data coming out soon. There is a study called PIT Stop, or paramedic-initiated treatment of sepsis targeting out-of-hospital patients. So this is a follow-up to that fantasy trial. This is being run out of Ontario, and they started enrollment in 2020, and they're scheduled to finish in March of 2025. They're enrolling about 2,000 patients. And in contrast to fantasy, which ultimately ended up enrolling a not particularly critically ill population, this is focusing specifically on patients with a systolic blood pressure less than 100. And then they're also randomizing people to intramuscular as opposed to intravenous ceftriaxone, because they did see that there was some delays in terms of even getting initial IV antibiotics in some of those sickest patients in fantasy. So we should be getting data from this in the next year or so. So that is exciting. All right, so I'll now move on and kind of talk about the flip side of the coin, which is this diagnostic uncertainty issue. And I'm going to return us back to that patient case that I shared about 10 minutes ago. So that patient case was actually a vignette that was shared as part of this survey to about 100 intensivists. And they were asked, how would you classify this patient's clinical course? Is this SIRS? Is this sepsis, severe sepsis, septic shock? None of the above. And the practicing intensivists came down really all over the map. So about a quarter said none, about a quarter said SIRS, about a quarter said sepsis, severe sepsis, and a quarter said septic shock. And they did a number of additional analyses, like dichotomizing sepsis versus not, or even limiting to only people who responded. They were highly confident in their assessment of this patient. And they still found that there was really poor inter-rater reliability across the respondents. And so they conclude that diagnosing sepsis is extremely subjective and variable. And so this kind of, led to a lot of concern in the field that, what are we doing? We don't know how to diagnose sepsis. But, it's unclear kind of how much this vignette represents kind of true clinical practice, right? Like certainly we see these patients, but how common are they? We also see patients who very clearly present with septic shock, and it's very obvious from the get-go. We see patients who very clearly present with, decompensated heart failure, and there's not this worry. So how how common are these patients? It's really hard for us to kind of know that just from our own clinical practice. So there have been a number of studies that have tried to look at this. How commonly are patients diagnosed with sepsis in clinical practice to then at the end of the day turn out to say, oh no, just kidding, these patients did not have infection. And so there's been three main studies that I'm aware of. The first one, published in 2015, looked at about 2,500 patients admitted to, I think, 2 different intensive care units in the Netherlands, all with sort of an admission diagnosis to that ICU of sepsis. And then they looked at the end of the hospital stay to say what was the definitive diagnosis when it was all said and done and all of their kind of diagnostic workup and treatment was completed. And in 43% of those patients, they said at the end of the day, we actually did not think this patient had infection. So that's a really high percentage. This study was followed up in 2020 by a study by Stephanie Taylor and colleagues. This was at Atrium Health in North Carolina. And they looked at about 4,000 patients with a code sepsis activation and found 38% of those patients turned out not to have sepsis at the end. Some of those patients had infection and organ failure due to other causes, so it wasn't a pure sort of 38% didn't have infection, but at least 38% did not have sepsis. And then finally, this study by Hooper et al., this one was out of the Intermountain Healthcare System. They looked at 8,000 patients and did chart reviews on all of them. And they actually found a lower proportion, so 9%, who ultimately had this diagnosis of sepsis overturned to be non-infectious. So I don't know, it's hard to know how often this happens in practice because there's a fair amount of disagreement. All of these studies are only maybe 2 to 3 hospitals, but the pooled proportion across what we know is around 22% come in treated and diagnosed as sepsis, ultimately turn out to have non-infectious cause. So we know this happens in practice, and my estimates are, maybe up to a quarter of the time. This issue of diagnostic uncertainty and overturning of diagnosis has led to a lot of vocal concerns that sepsis quality improvement is driving antibiotic overuse. And so here's just a number of different viewpoints, perspectives, editorials. And these all really argue this point that our time to antibiotic targets risk promoting antibiotic overuse and associated harms. And so for someone who's been involved in guidelines and now involved in kind of statewide quality improvement, this really led to this kind of like urgent unanswered question of like, is this actually happening? Is our focus on early antibiotics actually driving antibiotic overuse? Because, again, while this time to antibiotic literature is not 100% perfect, we have a compelling story that time to antibiotics are important for patients with sepsis. And while there's been a lot written about, causing rampant antibiotic overuse, there's very little in the way of empiric evidence. And so along with my colleague, Vinnie Liu at Kaiser, we applied for funding and were funded through Agency for Healthcare Research and Quality to try to address this question. And I'll share results from this paper. This was a paper published in JAMA Internal Medicine a couple of years ago. We tried to answer the question, when hospitals shorten their time to antibiotic delivery for sepsis, do they indeed prescribe more antibiotics or broader antibiotics as a result? And so for this, we used 152 hospitals. So this was nationwide VA and 22 hospitals in Kaiser. And the exposure was this hospital-specific temporal change, the average time to antibiotics from 2013 to 2018 among hospitalizations that met surveillance criteria for sepsis. That's the US, like the CDC surveillance criteria. And we had 273,000 hospitalizations meeting surveillance criteria. For the outcome, however, we looked at these temporal trends in the much broader population of patients who were kind of at risk for being treated for sepsis. So this was all patients presenting through the emergency department at these hospitals with positive SIRS criteria. So in total, over 1.5 million hospitalizations. And so we spent about a year really digging into the data to quantify this time to antibiotics, and we used barcode medication administration records. So this is essentially the nurse will scan the barcode on the medicine, scan the barcode on the patient's wrist, and then give the antibiotics. So it's kind of like as close to ground truth as one can get to know the time that these antibiotics were being infused, and then looking how this changes over years in a hospital. So some of this work was led by a mentee at the time, Max Wayne, who graduated from our fellowship a couple years ago and is now an assistant professor with us. And as Max was digging into this, we had a couple of interesting observations just looking at sort of time to antibiotics. We found that for these patients with sepsis, antibiotics were often being given faster in patients who presented febrile, but with normal blood pressure, as opposed to people who presented hypotensive but didn't have a fever. So people are really being driven by the obviousness that they present with infection, even though we know that it's super important to actually prioritize antibiotics in patients who present critically ill with low blood pressure. So that was one interesting finding. The other thing we found was just very significant hospital level variation, even after accounting for differences in the patient presentation. So the odds of getting antibiotics within 3 hours was about 60% higher in kind of our faster hospitals compared to the slower hospitals. So when we looked at trends over time across the study period, a 6-year period, we found that indeed, as a result of kind of large-scale efforts between Surviving Sepsis campaign and the SEP1, the time to antibiotics for sepsis had been declining substantially among hospitals in our cohort, on average declined by 37 minutes over the study period, and even greater than that in some of our hospitals. When we looked at these metrics for overall antibiotic use, however, we also saw that stewardship was improving. So the proportion of patients initiated on antibiotics among the all SIRS positive had declined marginally by about 0.3%. When we looked at the total days of therapy, this was looking at all antibiotics to day 30 in the hospital, and including for people discharged, antibiotics prescribed at discharge to be completed at home. We found compelling evidence that that was going down by, on average, about 0.6 days. And then when we looked at broad spectrum coverage, we found that, looking at a variety of different measure or kind of criteria for what was considered as broad spectrum, we found absolute reductions of about 2 to 4% over the study period in terms of proportions of patients receiving broad spectrum coverage. So first glance, kind of looking at the large, overall cohort, we didn't really see compelling evidence that shortening time to antibiotics for sepsis was driving overuse. But we also knew that overall cohort trends could hide concerning trends at the individual hospital level. And so then we took this analysis a step further and looked at how these trends correlated at the hospital level. And so in this figure, we took all 152 hospitals in our study and we plotted them on this figure. So the x-axis is the yearly change in time to antibiotics for sepsis. The farther left you are, the sort of faster things are getting over time. And then we plotted that against the hospital's change in overall antibiotic prescribing. So the average days of antimicrobial therapy per patient presenting with SIRS positivity. And you can see that the vast majority of hospitals are in this bottom left-hand quadrant. So about 85% of hospitals were simultaneously shortening time to antibiotics and reducing overall antibiotic use. So it's feasible to do both. And we found really no correlation between these two trends. So no evidence that the hospitals that had the greatest declines in time to antibiotics were suddenly giving indiscriminate antibiotics or impairing these otherwise kind of ongoing efforts towards stewardship. So our answer to this question of, is this focus on early antibiotics actually driving overuse, was that we did not see any evidence of this, at least not in the 152 hospitals in our study. The feedback, on this paper, I will say, these were Kaiser and VA, and so there are large systems that have invested in kind of system-wide efforts for antimicrobial stewardship. So it's not that, stewardship could never be an issue, but this is probably not as big of an issue as people had worried about in kind of all of these perspectives. All right, so I'm next going to go on and talk about kind of this third issue with the time to antibiotics literature. And that is that there's really been so much focus on the timing and relatively less focus on, well, which exact antibiotics are you prescribing to these patients? Obviously, we need to think about antibiotic selection too. And so for this, I'm going to share work by Rishi Shandaraj, that he is a early career assistant professor at University of Michigan who is on a VA Career Development Award, and I'm a sort of co-mentor on Rishi's team. And Rishi is a translational researcher, so he's done a lot of work looking at microbiome, sort of preclinical studies showing that eradication of kind of the healthy microbiome is associated with, bad outcomes. And so he's always hypothesized that really we should be trying to spare anti-anaerobic coverage in patients with undifferentiated sepsis, unless there's some clear, compelling reason why they would be at risk for this. And so in this study, Rishi sought out to say, is empiric anti-anaerobic coverage for undifferentiated sepsis without any specific indication for anaerobic coverage, is that associated with harm? And this was a really cool study because Rishi took advantage or leveraged this kind of nationwide shortage in Zosyn and used this as an instrumental variable. So this figure here, this study was just a single center study done at a University of Michigan. And so this shows the proportion of all antibiotics prescribed on a given day in our hospital, the proportion that were Zosyn in orange, and then the proportion that was cefepime. And clearly in the beginning, our kind of default practice for kind of undifferentiated, severe sepsis, septic shock was vanc and Zosyn, and that's what people were getting. And then during the shortage period, it switched. When we had limited stocks of Zosyn, we switched to predominantly prescribing cefepime. So there's very clear change in the prescribing patterns during this shortage period. And so then Rishi was able to leverage this as an instrumental variable to understand, well, what is the impact of being treated with cefepime, anaerobic sparing, versus Zosyn, anaerobic depleting. And across a number of different analyses, consistently showed that treatment with Zosyn versus cefepime was associated with harm. So there was about a 5% absolute mortality reduction for these patients empirically treated with cefepime versus empirically treated with Zosyn. So I think really, highlights that there's sort of more work to be done in terms of thinking about our initial empiric antibiotic selection, and certainly has made me a lot more cautious to cover people with Zosyn and trying to use something more narrow spectrum. And so this issue about empiric anaerobic coverage is a question that we are currently looking at for Surviving Sepsis Campaign guidelines and looking to include guidance on for the next iteration of the guidelines that are likely to be published in 2025. So I'll now kind of wrap up and talk about the implications of this various research for bedside care, guidelines, and then performance assessment. In terms of implications for bedside care, this is a perspective I wrote a number of years ago about sort of thinking about antibiotic framing across these two dimensions. How sick is this patient, meaning how urgently do I need to answer this question? And then how likely is this to be bacterial illness? And on that sort of illness severity thing, I had these things: shock, lactic acidosis, altered mentation, respiratory failure, that I thought were, cardinal signs of, higher risk of illness. And really many of those still are and make sense with clinical practice. But the work by Rachel with this causal forest has also made me start thinking about the acute hematologic dysfunction, metastatic cancer, and maybe some other factors that were borne out by the data for being particularly important for that, more prompt time to antibiotics, but still really thinking about these patients in terms of these two dimensions. And this is kind of borne out in this framework for guidelines. I think everything that's come out really since the guidelines framework has largely supported this framework. So I anticipate, but we'll see, that our guidance will probably be relatively unchanged. And this has been adopted into some other guidelines. For example, this is a guidance out of the UK that is used in their NHS system, where they have this kind of recommendation. They stratify their recommendations based on the NEWS2 score, so kind of an illness severity, and then based on their kind of gestalt likelihood of whether this is very likely, sort of probable, possible, or unlikely sepsis. So it's cool to see that this has kind of been adopted into some other kind of large-scale guidances and workflows. So how do we think about this for performance assessment and quality improvement? So I'll share what we are doing in HMS. So we measure and report antibiotic timing in all patients with non-viral community onset sepsis across our Michigan collaborative. We consider time zero as hospital arrival. And really that's so that you can't game it, right? We see that if we use things like vitals or labs, then people can kind of get rewarded for delaying the evaluation of their patient, because that delays the time zero, and we definitely don't want that. So we use emergency department arrival. And then we have differing targets based on whether when that patient presents, they are hypotensive versus not. And then in addition to reporting on time to antibiotics, we also report on the time from order to administration. We know that's a very important thing that can be improved with absolutely really no risk of worsening stewardship. And then we report on sort of hypothetical improvement opportunities. What would your performance look like if all of your orders were enacted within 30 minutes? What would your performance look like if all of your orders were 5% faster compared to they are now? And so they can sort of see where maybe the best opportunity for improvement lies as they work on their quality improvement. We're fortunate within HMS to simultaneously have sepsis initiative and this antimicrobial stewardship. So we also provide feedback about antibiotic stewardship and overuse in patients with, UTI or pneumonia or sort of questionable diagnoses of infection. So here's a snapshot of our performance evaluations. These are these quarterly reports that go out. And so you can see that we report out these antibiotics, like did they get antibiotics in the targeted time frame? Of those hypotensive patients, do they get it in 3 hours? Of the normotensive, do they get it in 5? And we have newly included this antibiotics within 3 hours for people who present with hypotension, meet clinical criteria for sepsis on admission. That's now included as a metric that's in this performance measure that's tied to paper performance. Across the state of Michigan, about 66% of patients with community onset sepsis, arrive hypotensive, receive antibiotics within our recommended time frame. But you can see that there's, pretty big variation on the margins in a number of hospitals that are kind of lagging, where fewer than half of patients are getting within those recommended time frames. We also see that nearly 30% of all hospitalizations, there's an over 1 hour delay from the time of that antibiotic order in the ER to the time of administration. So that's all things that we're kind of focusing on and working to improve over the coming years. So in closing, I hope I've convinced you that antibiotic timing is associated with outcomes, and in particular for these sicker patients. We do see evidence that antibiotics, however, may be delayed in these patients who are critically ill, but less obviously infected, not presenting with fever. I've hopefully also convinced you that it's possible to shorten time to antibiotics without driving overuse, but of course, we also always need to be mindful of stewardship and are really trying to balance these competing issues in the guidelines and make them sort of, sympathetic or empathetic to the difficulties faced at the bedside. Ultimately, kind of where are we going in the next 10, 20 years? I think there's like this critical need for better kind of rapid diagnostics. We still really based on sort of cultures which lag several days. And so I think we'll benefit from better tools as those come on in the coming years. I'd like to thank my many collaborators across the research projects, my study team, HMS, Surviving Sepsis Campaign Guidelines, and then thank all of you guys, and I'm happy to take questions.
Dr. Prescott, thank you. That was awesome. I'll ask you the first question, and I think you talked about it at the very last slide, which is where are we with those novel diagnostic tests that will give us sort of answers? I know earlier on there was this promise of procalcitonin and lots of work in that space. I know you looked at some of this as well in HMS. Give us some sense of kind of what you've seen and where you hope to go.
Yeah, it's a really good question. So I think there's like 2 different types of sort of rapid diagnostics that are coming on board. As one are just sort of like pathogen detection. And then the other are these kind of host response. So there's 3 different FDA approved tests now to say, does your patient have sepsis? Challengingly, those tests are really trying to differentiate sepsis from non, and they don't differentiate viral versus bacterial. So they're less immediately, in my mind, helpful for making this kind of clinical decision of do I prescribe antibiotics or not. And largely those have come to market based on showing that they are accurate, right? They like validate against some other marker of truth, not that they have been integrated into clinical workflow and improved clinical outcomes. And so in the guidelines, like for something to have a guideline recommendation and definitely a strong recommendation, it's always going to be based on, is there evidence that this can be incorporated into clinical workflow and improve an outcome or reduce the cost or sort of make some outcome better. Just being accurate is not going to be enough. And in terms of procalcitonin, so we do have a recommendation to use it for de-escalation, like that you can track it and stop antibiotics. We recommend against it for initial sort of assessment of whether this patient should get antibiotics or not. But I think that there is also now some movement for more rapid de-escalation. So rather than like talking about de-escalation on day 5, 6, 7, basically checking a second procalcitonin and saying, well, we gave them 1 dose of antibiotics, but maybe that was wrong. We can stop short. And so I think there will be some movement there potentially. So anyway, all of those things we are re-looking at for Surviving Sepsis Campaign Guidelines right now.
Terrific. Dr. Banish.
Great talk. Really enjoyed that. I was wondering how important, relatively speaking, do you think source control is? Thinking about the patient with obstructive uropathy or a ruptured appendix or a catheter-associated infection and sepsis, it seems to me like that could be a significant confounder when you're looking at the response to timing of antibiotics alone. Is it important to prompt source control?
Yeah, that's a great question and something I failed to discuss. But no, I completely agree with you. Source control is really important for people who have some kind of nidus of infection that either can't be cleared or that antibiotics are not going to penetrate. And so there was a I think, a fairly large study out of Germany like a couple years ago that looked at both time to antibiotics and time to source control, and does bear out the very same thing exists for source control. I think certainly there are some patients, right, who can be treated through, but a lot of patients with certain types of infections that are going to need timely source control. I think the data there is not quite as robust, but it makes good clinical sense. And we do have a recommendation about sort of urgent evaluation about source control and sort of pursuing of source control in patients who, are felt to need that in addition to antibiotics to improve the chance of clinical cure. So yeah, definitely a sort of an important piece. Antibiotics alone are not going to fix all of it.
Thanks so much. Is HMS moving to cefepime as their preferred antibiotic for sepsis? And is that going to be a quality measure for the network as well?
Yeah, so that's a great question. I sort of like had a slide on next steps that I ended up cutting for time. But yeah, so I think I'm interested, that was a single center study at University of Michigan. Rishi's has a career development award in the VA. So we are now looking and replicating that analysis in the entire VA system, which I think will help to bring more. And I think we want to look at it in the HMS data. So typically for HMS, we generally for performance measures will use things that either have a guideline recommendation or we can show in our own data are associated with outcomes. It feels a little egocentric to say, hey, my University of Michigan study showed this, therefore the whole state should do it. But certainly it's leading us to look into this and work in that direction. But I think we're probably tend to be a little bit more cautious to immediately put that into a performance measure. Yeah.
I have a question about your collaborative in terms of hospital size and resource and how that's factored in. And do you have different benchmarks for, say, critical access hospitals versus academic centers?
Yes, so it's a great question, Sarah. Yes, so another thing that was in my next step slide that I cut, but so we are fortunate that we're able to survey all of our hospitals twice a year. So we specifically collect a lot of data about like structures and processes and like, do you have an open ICU? Do you have in-house ICU? All these kind of things. And so as this sepsis registry has now grown and we have about 35,000 hospitalizations, we're able to start doing these analyses to understand what are the structural factors that actually associate with these better outcomes or seem to drive them. And so we're definitely looking into that. In terms of the benchmarks, we don't have like different benchmarks based on like a critical access versus non, but we do spend a lot of time thinking about that performance index, and we'll often have kind of like alternative criteria. So it's like you either need to meet X threshold or have a certain amount of relative improvement, because we're very mindful about not wanting to leave any hospitals behind and have hospitals say, why should I even try? I'll never be able to get it. We also even have an all or nothing, right? So this is like, it's the whole collaborative, and if the whole collaborative meets that metric, everyone gets money. And if the whole collaborative misses it, no one gets money. And that is intentional to try to make everybody have skin in the game, to not just be good themselves, but to help the other people be good too. So those are things we do. And then the last thing I'll say is for these, for the live dashboard, we're adding functionality such that they can toggle to say, here's what my hospital does. You can compare yourself to your geographic region. You can compare yourself to other similar hospitals based on sort of hospital size, or like compare yourself to other hospitals in your healthcare system, because people really want to be able to kind of do those different comparisons. And we know that obviously we can't expect that kind of like one size fits all in terms of outcomes or sort of processes will work across all these hospitals. So yeah, great question.
Hey, thank you so much. Great talk. I had a question. I was surprised about the degree of inter-rater variation in determining whether this clinical vignette had sepsis. Does that amount of variation make you worry that we need to, the guidelines are being misapplied, the definitions are too vague? Like what do we do with that? Because it feels like that's kind of a cornerstone of treating sepsis, is knowing it when we see it.
Yeah, so that's a great question. So I think a couple things in that study really inflated the degree of inter-rater reliability. So first, I mean, they sort of made this case that was super challenging, that clearly looked like they had two things going on. And so that was probably one of the more challenging cases that you're going to see in clinical practice, and not all patients are that complicated or confusing or murky. Secondly, I think they just said, is this sepsis? And I think that's a challenge because the sepsis definitions have changed over time, and people's mental framework of what is sepsis maybe differs depending on whether you trained in the era of sepsis 1 and SIRS, or trained in the era of sepsis 2, or trained in the era of the current sepsis 3, right? So things have changed. I will say that we have done some studies ourselves trying to have inter-rater people review the same chart and answer this question, but we did it a different way. We basically said the computer can tell us if acute organ dysfunction is present. So we pulled out all the acute organ dysfunctions, like okay, the patient has acute renal failure, their creatinine is 2. How likely do you think this acute organ dysfunction is due to infection? And then had that on a Likert scale, and we had way higher inter-rater reliability, sort of going about it that way. And so I think sometimes if you can kind of like unpack that clinical reasoning, you find that there's actually more agreement, because some of this agreement may just be like my definition of sepsis is lagging or is different, not that my sort of really clinical evaluation of this patient is different. So nonetheless, it's been a very provocative study that has kind of like been cited many times. And so, yeah.
Hallie, that was a great talk. I want to kind of flip it around a little bit and maybe build on the last question. Over the last 20 years, people are much more aware of sepsis, and maybe, as you alluded to with Stephanie and others' papers, maybe too aware that we're misdiagnosing and we're missing other diagnoses. And I worry a little bit that people will get admitted with a diagnosis of sepsis because everyone's thinking that, and missing diseases that are treated in other ways. TTP might be a good example, mesenteric ischemia, et cetera. Do you have any data about not so much the not giving antibiotics, but for the people that we think have sepsis that don't, that we're missing these other diagnoses, maybe they don't do as well, and what can we do about that?
Yeah. So Mark, I think it's a good question. And I think it is kind of borne out. Like if you look at obviously ICD-9 or ICD-10 based sepsis, you just think everything's kind of going up and up and up. And so in our HMS initiative, we have a 2-step process to identify eligible hospitalizations. We pull it in based on principal discharge diagnosis of sepsis, but also other common infections, pneumonia, COVID, flu, with my thinking being some of these people may have sepsis, but they just weren't called that. We find almost none of that. Way more often, we pull these people in with sepsis, and then when we do the initial chart review to say, did they meet surveillance criteria, we're kicking these people out because they just have SIRS criteria. They've got a white count of 14 and they're febrile, and there's no evidence of organ dysfunction, and we're no longer calling that sepsis. And so I do think there's been a huge pendulum shift. And that study by Stephanie Taylor, that was exactly kind of what they were looking at is, it's a whole smattering of other diagnoses. So I think one of the things they were trying to understand is there like a particular diagnosis that is being swapped out for sepsis? And it's really not. It's like a little bit of everything, right? Some of these people had a PE, some of them had heart failure, some of them had TTP, whatever. But I do think part of clinical medicine is not just kind of staying on this pathway, but every day reassessing, was I right yesterday? Does this patient still have sepsis? Like, should I still be continuing these antibiotics, and sort of answering that question? And so I think that's a really important message. And it is something that we try to put in the Surviving Sepsis Campaign guidelines. There's a thing that says every day reassess, are these antibiotics? Stop them if they're not. Because you'll see people even say, well, I don't really think they're infected. We'll just complete a short course of antibiotics. And I'm like, what is that? You should stop the treatment if you no longer think that's the problem. And so, yeah, I don't have a way of kind of quantifying what is the harm that is happening from that, but it's certainly, this kind of mistriage, is something that happens, in clinical practice.
Hallie, thanks so much. Enjoy your talk. A lot of the information you provided sort of evaluates patients that are coming from the sort of outpatient setting into the hospital with diagnosis of sepsis. And after just spending a week in the ICU, we see patients that have a diagnosis of an infection, and they suddenly get worse, they develop shock, and we make either antibiotic changes or we start antibiotics and we'll say, okay, let's culture them and see what happens in 48 hours. And if it's negative, we'll stop. I mean, what about those practices? Is it really the right thing to do?
Oh, with those antibiotics, you're saying, yeah. So if you're bringing up these kind of like potential hospital onset sepsis, which, yeah, has been kind of like an even more challenging diagnosis, I think, to study and to treat. We know that this is like 1/8 of all sepsis cases or less, but it's like maybe up to 1/3 of sepsis-related mortality is people who develop sepsis in the hospital because they're already critically ill with something else and now they've got sepsis. So I do think there's, a number of people that are sort of trying to look in, like Dr. Ganestra here is looking into hospital-based sepsis, and I have a mentee who's also interested into that. And I think we need specific studies, right? Because I think largely the sepsis literature is focused on like ED-based studies, community onset sepsis, and we've just taken that and kind of applied it to hospital onset sepsis. And it's sort of unclear that all of this paradigm, things like fluid resuscitation, should really be the same. Because, these patients weren't kind of at home with fevers and, poor PO. They've been in a monitored hospital setting, potentially getting IV fluids and nutrition, right? So everything may be slightly different. And I think there's a need for more studies. I think we all do the same thing of, putting them on antibiotics. When I think about that, I think about that framework of like, how sick are they, and sort of how likely is this to be infection. And I always try to ask my house staff of like, do you think they've actually gotten sicker, right? Like if the patient just happened to spike a fever, or they happen to have their white count as 14 and it was 12 yesterday, like there's so many data points in the ICU. And if you're acting on one data point, like you're probably going to be going in the wrong direction. Like that's a reason to maybe evaluate them, do more of an exam, think about where might they be infected, can I D-line them? But I want to say like, is this patient gotten sicker? If the patient's gotten sicker, I think it's more likely that they have infection. And if you push people on this question, they'll say, the night team will say, they spiked a fever, so I started them on antibiotics. I'm like, oh, do you think the patient got sicker overnight? They're like, no. And so I try to always kind of come back to like, do you think this patient has had a clinical decompensation, not just like one of the 55 parameters we followed looks slightly worse today.
Thank you so much for this talk. Over here.
Oh, hey.
Hey, Andrew with Medicine. I had two questions for you. One is you were saying at the beginning of your talk that there's several patients that do worse with sepsis. One of them was patients with hematologic dysfunction. So wondering if you could define that for us of who exactly is included in that category. And the second question is, it sounds like it's a little unknown if like some of these antibiotics that cover anaerobes are long-term harmful or not. It just made me think about how with pneumonia now we're moving from the ceftriaxone and azithro combination to Unison and Doxy. And what are your thoughts around that?
Yeah, great question. Yeah, so I do have concerns about this, anaerobic coverage, and personally, I'm like more apt to spare things. And I think about that in a couple different ways. So yes, I get worried about this Unison coverage. I also think about patients where we're trying to like de-escalate. And sometimes in the process of de-escalating, you actually broaden the overall spectrum, like you de-escalate to like Augmentin or something because it's oral, but now suddenly you've given them anaerobic coverage when they never had it. I personally tend to try to continue the same antibiotic for one more day. I continue for one more day and stop. I'd rather do that than put them on a whole new different antibiotic unless that coverage spectrum is fully subsumed within the initial one. So yes, I do worry about that. And again, it's a single center study. There's risk for confounding, but there's very strong preclinical data that this kind of destruction of anaerobic microbiota is going to be harmful. And then, then the first question you had was about the hematologic dysfunction. So again, that was differentiating patients who have a greater treatment effect from shorter antibiotics. So it's saying timely antibiotics are particularly important in people with those factors, as opposed to people where it doesn't really make them as much of a difference whether you get it at hour 1 or 2 or 3. And so specifically the way acute hematologic dysfunction was defined in that study is it's the same criteria that is used in the CDC surveillance criteria. So I think you have to have a platelet count of less than 100,000, and then it has to be at least a 50% relative reduction from your baseline. And so in that study, the baseline was based on either your best value in the whole hospital stay, so like if it recovered subsequently, or on a 6-month look back. So because the study was in VA and Kaiser, we actually had all the outpatient labs leading into hospitalization. And so we had baseline labs on about 75% from pre-hospital. And so if we had, so anyway, whatever the best value was in like -6 months to hospital discharge, that was considered baseline. And if you presented both less than 100,000 and 50% relative reduction from your best, then that was considered acute hematologic dysfunction for that study.
Any last questions for Dr. Prescott? We're almost at time. Oh, one more over here from one of our chief residents.
Thank you for your great talk. I'm wondering, as a future PCP, for our outpatient providers, are there any tools or resources you would recommend for either screening or monitoring the long-term sequelae of sepsis?
Oh yeah, excellent. Yeah, so long-term sequelae, super common, not to toot my own horn, but like I wrote a review on this with Derek Angus, which was published in JAMA in 2018, which was it was like sort of a systematic like summary of the literature of everything we know about kind of enhancing recovery. I would say that's probably the thing to cite. It sort of looks at what are the most common sort of new problems at the time, like immediately after hospitalization, and also like what are the risks going forward? What are the common causes of medical deterioration post-sepsis that end people back up in the hospital? And then I would say there's kind of like we have a new section of the Surviving Sepsis Campaign guidelines devoted to long-term outcomes, and we will be continuing with updates to that for the next guidelines. And then I didn't have time to mention this other study, but we're working actually on this over sepsis or optimizing veteran recovery from sepsis. And we're doing like a Delphi panel over the coming year for guidance related to kind of practices in this peri-discharge periods, with hospital discharge and immediate outpatient follow-ups, or like what are the most important things to focus on promoting kind of a sustained and full recovery for patients. So thank you for your question. Super important. Yeah.
Dr. Prescott, thank you very much. This was awesome.